Yeah, good evening, one and all. I heartily welcome to today's webinar on approach to the patient with acute abdomen, which is organized by McWorld Expo in collaboration with Cygnus Hospital. I'm delighted to have you join us for this insightful session. It is aimed at enhancing clinical knowledge and patient care. Before we move on to the webinar, it's our privilege to introduce Dr. Srivenu Itha sir, who is a distinguished senior gastroenterologist based in Hyderabad, who is having over 20 years of experience in the field. He completed his MD in General Medicine from AIIMS New Delhi, followed by a doctorate of medicine in gastroenterology from SGPGI Lucknow. He further enhanced his expertise through fellowships in the USA and Belgium. Dr. Srivenu sir is currently associated with Cygnus Institute of Gastroenterology, which is a premier 50-bedded specialty hospital based at Hyderabad. Established 15 years ago, this hospital is MABH accredited and also offers a DNB training program. Now the institute is supported by a dedicated team of senior gastroenterologists. All are working full time to provide advanced and comprehensive care to the patient. Today I am looking forward for an engaging and informative discussion ahead and requesting Dr. Srivenu sir to start over the webinar. Thank you, sir.
Thank you very much for that kind introduction. At the outset, I would like to thank two people. One is MedWorld Expo, for coming up with a unique idea to really impart the clinical skills to the young budding doctors. This is a very important, unique concept, I would say, bringing together as a bridge between the senior people and budding doctors. And again, I would like to thank all the participants for showing the keen interest at this time, at this hour, to foregoing, sir, you use very important time and coming here to learn this important topic. I'll make sure that I think it's going to be a very useful next 30 to 45 minutes, I think, because what I'm going to talk now is a very practical aspect which you're not going to find it in the textbooks. Because acute abdomen is an emergency entity wherein you need to act fast. You need to understand, make a diagnosis fast, when to do what investigation, when to send the patient for surgery, because these are all practical aspects. So I'll take you through the journey, how to make a diagnosis, how to solve a difficult problem, when to refer to surgeon, when to do which kind of investigations. So these are all very practically very important things which you need to learn, because time is more important than any other thing here, because we cannot send a patient, someone with a perforated abdomen, to a x-ray. Again, you are creating a problem because patient might die waiting for the x-ray in the radiology room. So today's talk will help you understand how to triage the patients, where to put which patient, where, how to act, and where to put the patient. So I'll be talking about some of the important clinical diagnosis, how to make a diagnosis, when to do which investigation, and how to treat them. And towards end, I'll talk about some of the rarer problems. So I'll make it a very clinically important thing. And we'll start now.
Yes, please, sir.
So what I see is only what mind knows. Suppose if you are very new to an ECG, you cannot make a diagnosis of an MI. It has to be there in your memory to make a ST, to look at the STT changes to diagnose MI. Similarly, acute abdomen is again an entity wherein you need to be aware of what are the things exist, how to make a diagnosis. If it is there, it exists in your memory, then only you can make a diagnosis and you try to look the same thing in the patient. So always develop a kind of memory of all the important things which I'm going to talk about now. So today's learning objective is going to be to make you familiar with the most common cause of acute abdominal pain and to segregate the patient, which is very important, of the patients who require surgery versus no surgery, and to select appropriate imaging techniques in the diagnostic workup, because this is an emergency scenario. We cannot write a wrong investigation. So you need to know which investigation has to be used. This again depends upon what is the diagnosis you made. So initially, there's a lot of clinical judgment goes. Based on that, you make a diagnosis. Based on that, you choose appropriate diagnostic workup. And finally, to learn the pitfalls in the diagnosis, that you need to be aware. When I'm writing an investigation, how sensitive it is, how specific it is, how much I can really rely on this investigation. So combining all these things, we try to go deeper into the today's topic of acute abdominal pain. So acute abdomen is a pathophysiological process that has a sudden onset and may require a surgical intervention. So as I go through this presentation, just think about these are the three different scenarios I've put. Think about the possible diagnosis. I know it might be difficult for you, but have a curiosity, because curious mind is very important to make a diagnosis. First entity, I put a 18 months old baby who developed a sudden became suddenly crying from acute abdominal pain while playing. Other is a 20-year-old young adult came with 12 hours of diffuse crampy abdominal pain that later migrated to right lower quadrant that became very sharp and continuous. Third entity is a 70-year-old old woman came with a past history of chronic steroid usage. Now I came with a sudden sharp abdominal pain and with a rigid abdomen. So ponder about this common, one of the entities, what could be the diagnosis? I mean, it must be crossing your mind, but still keep it in your mind. We'll go through these cases again later on. So I kept a mnemonic for you to people to, because this history is very important. When your patient comes with abdominal pain, try to use this mnemonic to make a diagnosis. See, most important in making a clinical diagnosis as far as possible. See, you need to limit your diagnosis to 2 or 3, not more than 3. You cannot make a differential of 7 or 8 because you need to act fast. You need to choose appropriate investigation. So these are the clinical parameters which you can use as a mnemonic to make a diagnosis. See, if you stick to these 7 parameters, I would say you'll be certain in 90 to 95% of cases in diagnosing acute abdomens. So how important it is, you should need to understand. So I put a mnemonic as old cars so that you can easily remember. O stands for onset, L for location, D for duration of the pain, C for the character of the pain, and A is alleviating or aggravating factors associated with symptoms. R is radiation. Are there any radiations? History of radiation. And how about the severity? So if you give importance to all these subsets, then you can make a very good diagnosis of the cause of the acute abdomen. Now we'll delve deep into these things. So again, physical examination, before going to there, physical examination is very important. Have a look at general appearance of the patient. Is the patient looking sick or non-sick? Is the patient mobile versus still? Or is the patient had a past history, now is he comfortable or still continues to have the severe pain? And finally, not to forget the vital signs. Vital signs include blood pressure, heart rate, consciousness level, breathing, saturation. All these are very important. So in the mnemonic old cars, location, I would give the highest importance. So when the patient comes, historically, you can ask, where exactly you are getting the pain? Or you can examine and locate the pain also. If the pain is confined to right upper quadrant or epigastrium, the differentials remain liver, biliary colic, pancreatitis, or gastritis, or peptic ulcer disease. If the pain is below the umbilicus and suprapubic level, probably colonic pain is considered. And if it is along the groin or the lumbar area, you can consider ureteric pain. Or the pain is towards the back on the below the right scapula, you can think of the biliary colic radiating back, or it is radiating midline back, you can think of pancreatic pain or renal pain. And finally, ureteric and rectal pain can be in the midline back in the lower back. So these are the location you should need to look when the patient comes. As I told you in the old cars, the most important thing is localization of the pain. So again, if you're suspecting a bowel pathology, then upper abdomen confines to this pain probably arising from stomach or duodenum, or the pain is periumbilical. You can consider pain arising from jejunum or ileum, and the pain is in the lower abdomen. You can consider the possibility of colonic pain as a cause. See, this is only foregut, midgut, hindgut. This is only for small colonic pain, which can be has a poor localization. You need to understand it has a poor localization, but still it can be confined to the upper, middle, or lower abdomen. So if the patient complains pain in the right upper quadrant, consider these are the differentials. It is acute cholecystitis, biliary colic due to the gallstones, or it can be hepatitis, acute pancreatitis, renal colic, peptic ulcer disease, pneumonia, pleural effusions, and myocardial infarction. See, not to forget MI. Any upper abdominal pain in acute abdomen, always not to forget. I'm telling you again, highlighting, not to forget. If the person is above 50, of course, these days, even a younger patient, not to forget doing an ECG, because we are not supposed to be miss an MI. So upper abdominal pain, just don't put a pantoprazole or a Buscopan and send the patient. Always, please do an ECG, always. If the patient has a left upper quadrant pain, consider the references as acute gastritis, gastric ulcer, acute pancreatitis, pain related to splenomegaly, splenic rupture, renal stones, pneumonia, pleural effusion, again, MI. So these are the differentials based on the location of the pain. If the pain is in the right lower quadrant, think about acute appendicitis, renal ureteric colic preferably, ovarian cystic pain, especially torsion cyst, tube-ovarian abscess, ruptured ectopic torsion, epididymitis, ectopic pregnancy, ruptured aortic aneurysm, UTIs, or if it is in the left lower quadrant, think about the diverticular. Diverticular predominant location is sigmoid colon is the commonest location. So you tend to get the pain in the left lower quadrant. Ureteric colic, again, ovarian cyst, torsions, ovarian cyst, epididymitis, ectopic pregnancy, aortic aneurysm, UTI. Abdominal pain can be due to the visceral origin of the visceral organs, or it can be parietal pain where I'll talk about this, or it can be referred pain. I'll delve deeper into what are these different kinds of pain and how do they present and how you should, when do you suspect? When do you suspect what we are dealing is a visceral pain? When should we suspect, are we dealing with a parietal pain? And when should we consider a possibility of a referral pain? Referral pain is something, as you all know, pain is different, organ of origin is that somewhere else. So how we'll go deeper into this. So what type of pain is really the patient experiencing? Is it a visceral pain, parietal pain, or referral pain? Suppose if it is a visceral pain, it normally occurs when an organ is involved, solid organ or bowels. So more visceral organs to be precise. And most these organs do not have a somatic nerve ending. They're all innervated with the autonomic nervous system. And pain is predominantly due to the distension, stretching, torsion, or irritation of the visceral peritoneum. And visceral pain is normally, most of the time, it is diffuse, dull, ill-defined, crampy, and is associated with sweating, nausea, and vomiting. Consider a patient with gastritis pain. It's poorly localized. Intestinal colic, poorly localized, but crampy. But when there's an obstruction, intestinal obstruction or gastric outer obstruction, you can have a nausea, vomiting, or as a reflex phenomenon, also you can get nausea, vomiting in any kind of visceral pain. See, vomit, just because the patient has a vomiting, you should not think it as a gastric pain or intestinal obstruction. Any visceral organ pain can have an associated nausea and vomiting. So always remember, nausea and vomiting is a sign of a visceral pain rather than a gastric or intestinal colic. Next comes the parietal pain. See, this signifies a peritoneal involvement. Parietal peritoneal involvement. And now the pain becomes more localized. What you can elicit is a guarding, rebound tenderness. Please don't elicit rebound tenderness. It's very painful. You can see when you touch the abdomen, if the patient abdominal wall becomes rigid, that means he is trying to protect his peritoneum. by not allowing to touch it. So this is what we classically call guarding. If the guarding is a McBurney's point, you can consider it as appendicitis. So similarly, guarding is a sign of that visceral pain is touching the parietal peritoneum, thereby resulting in the spasm of the abdominal wall, abdominal muscle when we are palpating. And these are the people, when they come into the casualty, they try to avoid moving. They try to remain still because any moment will irritate the parietal peritoneum, thereby causing pain. Next comes, I think, referred pain. This is very important pain. Sometimes patient can present with the right shoulder, left shoulder, back pain alone. If the patients complain back pain alone, don't think it as a musculoskeletal pain. Always take a deeper history. It can be pancreatitis or it can be perforated peptic ulcer. Or simple peptic ulcer also can just radiate to the back. If it is a shoulder pain, think of a irritation of the diaphragm, or it can be arising from the gallbladder. Similarly, abdominal pain can be because gastritis and renal colic, as I told you, can plainly refer to the lower back. Because this is because visceral organs do not have a somatic nerve endings. They get transmitted to the dermatomes. From there, it gets to the somatic nerve pain. So, pain is visceral, but they go to different dermatomes to which these visceral organs are connected. This resulting in brain misinterpreting due to the it has a pain arising somewhere else rather than it is arising in the visceral peritoneum. So again, as I told you, right shoulder, think of right diaphragmatic pain, liver, gallbladder, or pneumoperitoneum. If it's the right scapula, think of biliary tract origin or gallbladder. Left scapula, think of splenic origin or from the tail of pancreas. If it is the left shoulder, it can be due to left diaphragm, spleen, pancreas, or stomach pain. Back is always remember, if it is a back, aortic aneurysm rupture can be a cause. Pancreatic pain can be a cause, or perforated duodenal ulcer also can be a cause. If it is a pain felt in the groin or genitalia, think of a ureteric, kidney origin, or aortic or iliac vessels. So these are all the referred pains where you think of the, not to forget the visceral organ as a source of this pain. Very important, character. Again, in the character, I think what we need to remember, how is the patient's classical description of the pain? Before that, I think I want to talk in the old cause mnemonic onset. Onset, I didn't put a slide, that's why I'm telling it verbally. Onset, I think if a patient tells, sir, I had this pain started, I think, in the midnight at 1 o'clock, or at midnight at 12 o'clock, or in the afternoon 2 o'clock. If the patient is very precise on the onset of the pain, think of a 3 or 4 entities only. One is perforated duodenal ulcer. Second is aortic aneurysm rupture, or it can be ruptured ectopic pregnancy. So these are the differences you should think when the patient precisely tells the onset of the pain. These are the 4 differences you should always remember, because here you need to act very urgently. Now it comes to the character of the pain. You all know intestinal pain is always colicky, which has a waxing, waning, and there's a pause. Again, there's a waxing and waning and a pause. That's a classical intestinal colic. Gastroenteritis pain is a milder in severity. It has a pain start, wait, stay for some time, falls down. If it is intestinal colic, as I told you, it has a classic colic. If it is acute appendicitis, remember, pain intensity continuously increases. There is never a pause. Acute appendicitis will never have a pause. If the patients had a pain in the morning, now it is not there. Again, it started yesterday morning. I had a pain. Afternoon, it disappeared. Again in the night, it's not appendicitis. Appendicitis patients, it is a continuous pain which is gradually increasing in intensity. This is a feature of acute appendicitis. Never a gap in the pain. As I told you, ruptured aortic aneurysm, pain, very precise onset, and one of the very severe pain, it's unending intensity, gradually, continuously increases. There's no normal status quo kind of a pain. If the pain has a severe intensity, but remains same intensity, then it is a pancreatitis pain. So remember the character of the pain. You can see in the pictorial diagram. Look at the severity and over the time. As I described, see, this kind of a character requires a deeper probing into the history. because we need to make these differentials. We need to make this diagnosis. This all comes from the experience, but start using this, whatever I'm telling you today. So as I told you, you can see this picture, sudden pain, always think of the perforated peptic ulcer, mesenteric ischemia, ruptured abdominal aortic aneurysm, or ruptured ectopic pregnancy. 4 differentials, sudden onset pain. Localization, as I told you, you can see all these things. And character I already described, rest I think already I talked about. So the problem in the acute abdomen is you need to make a diagnosis. If you operate and the problem is not surgical, patient is exposed to unnecessary risk and anesthesia. It all depends upon your clinical acumen, because the risk is great if an old man had a simple DU ulcer. He had a concomitant, he must be on steroid, he must be on antiplatelet, he must be on several other medicine, he must be having comorbidities like diabetes, diabetic nephropathy. With all this problem, if you put this patient to anesthesia and surgery, not to forget there is a outcome can be adverse. See, always choose a patient, right patient. So for this, you need to make a diagnosis. So again, other half also is very dangerous. If you go to other spectrum, if you do not operation, the problem is surgical. Patient is at risk of wrong therapy. Sometime you can delay diagnosis, delay the surgery. It can be a fatal in some patients. So both ways it's going to be a problem. You need to make a right choice in that appropriate time which is given to you by using appropriate clinical diagnosis, appropriate investigations. So common diagnosis, if you see a spectrum of patients of 100 patients of acute abdomen, I would say broadly, appendicitis remains 1/3, cholecystitis in up to 10%, small bowel obstruction in 4%, gynecological cause can be in 4%, pancreatitis in 3%, ureteric or renal colic in 3%, peptic ulcer in 2%, cancer can be a cause in 2%, diverticulitis in 2%, and diagnosis is uncertain in up to 1/3 of the patient despite a very good clinical history and good examination, even after all these things. So how a patient requiring a surgery looks. This is an experience with comes, you'll see, start looking at it. Patient normally will be in acute pain. He looks septic and toxic look, board-like abdomen, absent bowel sounds, high WBC, and there's a free air and a diaphragm. These are the patient I think you need to act fast. Similarly, non-surgery patient normally has a robust appearance, looks trivial. Palpate the abdomen, it looks soft, bowel sounds are intact, WBs are normal. If you do a basic investigations, like upright films of abdomen, they remain normal, or an ultrasound, then you can see that this patient might not require emergency surgery. I'm not saying that he might not require surgery forever, but may not be an emergency. Surgical, see, there are some surgical acute abdomens. How fast you need to act? I divide into 3 groups. Which are the patients you need to shift to OT immediately without not even a single investigation. As I told you, ruptured abdominal aortic aneurysm. Even if the patient waits for few minutes to maybe minutes to an hour, it can die. So that's why if you can make a diagnosis, how to make an immediate diagnosis at the bedside, I'll tell you other than a clinical history. Second thing is ectopic pregnancy. You need to shift this patient immediately because they might die of hemorrhage and shock. And the patient, after the trauma, develops a ruptured liver, ruptured spleen. They can die because of shock due to hemoperitoneum. These are the patients you can make a diagnosis at the bedside by doing some simple investigation. What was it? I'll let you know. So these are the patients. Just right from the emergency, you have to shift them to the OT. Not even a single investigation. Next comes urgent, wherein you can wait up to 6 hours, not beyond that thing. So these are the differences which include perforated viscous, which can be a gastric perforation, duodenal perforation, or any bowel perforation, which can be intestinal perforation, or the patient has an acute appendicitis. I think preferably make a diagnosis as early as possible and send the patient to the surgery. If it is a strangulated hernia, because these are the patient, because ischemic bowel, you can land up in a perforation, again resulting in a perforated peritoneum. So again, you don't want to see that thing happening. So these are the patient, make a diagnosis and shift them to the OT as early as possible. Non-urgent remains acute cholecystitis, diverticulitis, bowel obstruction, and incarcerated hernia, but there is no strangulation. Red flag signs, you need to look how the appearance of the patient. Is the patient responsive or unresponsive? Is the patient in shock? How are the vitals? And how severe is the pain? These are the four things I think make us early judgment, what are the situation we are dealing with. Now I talk about briefly about acute, because this is being a very common entity. You people need to know how to make it. See, acute appendicitis is a clinical diagnosis in 90% of the year time. We only use these days mainly CT for medical legal purpose, not to make a diagnosis of acute appendicitis. I'm telling you again, acute appendicitis is a clinical diagnosis in 90% of the time. But even after that, since they give time, if they we can still, if the center is able to do a quick CT scan, if the surgeon is ready, I think you can send the patient to a CT and quickly take him for surgery. But if you don't have all the facilities like CT, don't refer the patient to CT elsewhere. In that situation, make a clinical diagnosis and you can take the patient for a surgery immediately, because acute appendicitis has a very classical presentation. So I put this mnemonic as PANT. P refers to the pain, A refers to the anorexia, lack of appetite, and T refers to the temperature. Normally, most of these patients have temperature, and N refers to the nausea and vomiting. Classically, most of the time they are present. As I told you, pain is a continuous pain. Pain is most of the time you get a pain, patient complain this pain is there for more than 24 hours, because pain starts with a low grade intensity, gradually picks up without any gap in between. So most of the time when the patient comes, you can get an history eliciting has a pain more than 12 hours. If you keenly go into the history of the pain, they complain the pain as initially poorly localizing periumbilical. But as the pain progresses, this pain tend to become right lower quadrant towards the McBurney's point. So this is how you make, and you can elicit after if the pain is there for 6 to 12 hours, now we can have a guarding and you can elicit pain tenderness at the McBurney's point. So what are the points favoring the diagnosis in the one is elevated WBC is seen most of the times. Pain is localized right lower quadrant. Most of the time, it's more than 12 hours. Normal associated with vomiting, rebound tenderness, and guarding. Factors against diagnosis are normal WBC, pain more than 48 hours, because very rarely the patient comes later after 48 hours. And the pain is not localized to right upper quadrant when the pain is for more than 12 hours, it gets localized to right lower quadrant. If the pain is poorly localized, even after 24 hours, very unlikely it's acute appendicitis. But of course, we can have an atypical presentation, especially when the appendix is retrocecal. This is a situation wherein you will not elicit, it is a poorly localized pain, and you will not elicit tenderness at the McBurney's point. So that's why I said 90% you can with certainty we can make a acute appendicitis. But if the diagnosis remain uncertain, the patient acute abdomen, yes, CT can be a very important modality, and I'll talk about that later. Intestinal obstruction, it constitutes 3 to 4% of all acute abdomen. Remember, when you're suspecting intestinal obstruction, most of the time, it's 3/4 of the patient you can elicit a history of previous surgery. Because the most common cause of intestinal obstruction, if you get an MCQ in exam, it is adhesions is the most common cause. Post-op adhesion is the most common cause. Other causes in the absence of previous surgery can be hernias. Hernias can be umbilical hernia, inguinal hernia. So that's why in the examination, always look for the hernial orifices, because patient might not notice the inguinal swelling. You need to look at the inguinal orifices. Is there any hernia? So sometimes intestinal hernia, prolapse of the hernia through the inguinal canal can cause an obstruction. And sometimes internal hernias also can be there. So Other cause can be tuberculosis, tumors of the peritoneum, tumors of the small bowel, any solid organs. Intussusception can be a cause. Malrotation and bands also can be a cause. So now when you make a suspicion of intestinal obstruction, how do you differentiate whether the gastric-duodenal obstruction or jejunal obstruction or colonic obstruction? Remember, if the pain is severe intensity, colicky pain, severe intensity, see, in all these situations, you might get a colicky pain, but the intensity of pain is more severe in colonic pain. Less intensity in gastric, somewhere in between in jejunal. If the distension is predominant, consider colonic obstruction. Almost no distension, think of gastric or duodenal obstruction. Somewhere in between, think of a jejunal. If the vomiting is profuse, think of a gastroduodenal obstruction, because vomiting is almost a rare entity in colonic obstruction. Again, jejunal ileals fall somewhere in between, and it can be a bilious vomiting or feculent vomitings. So remember, pain is more, distension is more in colonic, vomiting is more in gastroduodenal. Dehydration, metabolic alkalosis or metabolic acidosis is more common in gastric, duodenal, jejunal. So these are some important differences. See, we need to make a diagnosis. Suppose, for example, if you're suspecting a jejunal or colonic obstructions versus gastric or duodenal. Gastric, see, you tend to miss out even, the choice of investigation matters in these situations. Gastric or duodenal obstruction can be missed out in CT scan. Jejunal, ileal, colonica tend to be made a very good diagnosis in colonic obstruction. Sometimes we need to do a colonoscopy depending upon situation. See, always making a diagnosis before is always important. This help in choosing an appropriate investigation. So historical, what all the things you need to ask, I put it as this slide for especially for you to make a diagnosis. Another rarer entity, but not to miss, because this is a very dangerous entity. If you miss, it can be a dangerous, it can kill the patient. So you need to make an early diagnosis. So clinical features include in the early stage, what you see is a pain is disproportionate. If you examine the patient, soft abdomen, but the pain is disproportionate, not responding to regular regular analgesics. So these are the patient, when the pain looks intense, but the patient look abdomen is soft, vitals are soft, vitals are normal. Think about, are we missing acute mesenteric ischemia, especially if you're dealing with an old man with comorbidity, especially coronary disease, because normally most of the patient will have underlying coronary disease. They might have had some coronary disease, coronary intervention in the past. So these are the patients when they come with abdominal pain with poor localization, but intensity looks severe with minimal physical signs. Think of acute mesenteric ischemia. Late stages, you can get a distension. This is because of now the bowel is going into ischemia after the infarction. These are the patient developing distension, ileus, tenderness mean there is already bowel might have perforated. See, if you operate a patient of acute mesenteric ischemia with a perforated bowel, the mortality is 90%. No surgeon will operate a perforated viscus due to the acute mesenteric ischemia. So that's why early diagnosis is very important. It's nothing can be done if the patient comes with shock and generalized peritoneum due to the bowel infarction causing a perforation. So early diagnosis is the key. So causes, it can be arterial embolism, which can be from the heart, which can be the patient has a pre-existing heart disease, which can be because of atrial fibrillation, or it can be due to the coronary arterial thrombosis, which can be superior mesenteric artery, inferior mesenteric artery, or celiac artery. Thrombosis can be anywhere. Depending upon the where is the localization, based on that length of the infection, how much is occlusion will dictate how fast occlusion happen, will dictate the severity of the infarction, severity of the ischemia. Sometimes it can be non-occlusive mesenteric ischemia in 15% of cases. Venous thrombus also can be a case in 10%, which can be mesenteric vein thrombosis, or most commonly it's a mesenteric vein thrombosis. Remember, CT is a very good modality for a quick diagnosis when you're suspecting acute mesenteric ischemia, if you make a diagnosis, send the patient for CT scan for a very quick and early diagnosis, because CT is 90% sensitive, 90% specific in making a diagnosis. Angiography can be used, especially when you see some amount of occlusion in the vessels, but the bowel remains normal. Treatment removes thrombolytics or surgery depending upon the kind of an occlusion we are dealing with. So finally comes non-significant abdominal. See, this is a very common thing, but it should be an exclusion rather than making a diagnosis. Rule out all the causes of acute abdomen, then you land up here. This is a non-emergent entity, and this remains the most common cause of abdominal pain and remains up to 1/3 of the patients who are presenting with acute abdominal. Chronic abdominal pain, of course, 95 to 90% are non-significant abdominal, but in acute abdomens, up to 1/3 can be non-significant. Sometimes you can see patient with hypochondriacs coming with as acute abdomens. That also can be a possibility. And pain normally abates in 24 to 48 hours, and incidence decreases with age. Highest incidence is in pediatric patient. No diagnosis, definite diagnosis can be made in this patient. Patient with non-significant abdominal pain usually have repeated episode. Ask for the past history. If they elicit a similar kind of history in the past, similar kind of visiting with a similar pain to with other doctors, now we are dealing with the possibility of non-significant abdominal pain. And 90% of the time, these people have a normal leukocyte count and normal C-reactive protein or ESR levels. You can sometimes even do a C-reactive protein and to make a diagnosis, are we dealing with a non-emergency functional entity? And now I'll talk about the special situations. So as I was discussing about the patient in the previous one of the slide, I was telling 18-month-old baby presented to the emergency department with incessant cry, which became inconsolable. Think, do a finger examination. If you see red jelly stools, think of intersusception. You're not supposed to miss it. Intersusception is one of the diagnosis in pediatric population which you're not supposed to miss. Normally, baby will have a continuous pain. Next comes the elderly patient with acute abdominal pain. See, remember, elderly patient, atypical presentation is the rule. See, functional pain is very rare in elderly patients. Always have a very keen, close eye. If needed, do a definite investigation. Never send the patient by giving simple treatment, because atypical presentation is a rule in these patients. Mortality is 4 times greater, and need for immediate urgent surgery is more than double, and post-op complications are 60% higher in these patients if you delay diagnosis, and 24 delay in surgery makes mortality very high. So remember, elderly patient, extra caution. Functional abdominal pain is very common in children, especially toddlers and a teenage, from maybe up to 5 years to 20-25, it can be very common. But again, use all the things, whatever I explained so far, to make a diagnosis. If you're not able to fit into all these things, then you can consider possibility of non-significant abdominal pain. Now I talk about the investigations. I think these are regular investigation. I'll not go into it. Remember, I'm not a big fan of abdominal radiograph. In acute abdomen, very rarely you can make a use out of acute abdomen. Remember, radiation is very high. One abdominal X-ray is equal to 50 chest X-rays. The amount of radiation you're exposing to them is equal to 50 chest X-rays, because you're exposing whole of the abdomen, broader radiation, and it's not good. These are the patients, because radiation has inherent risk of, it's carcinogenic with a later risk of. So always, the only place where I really bank on abdominal X-ray when you're suspecting an intestinal obstruction, wherein you don't want, the patient cannot afford a CT scan. So that is one entity really. I have to use the abdominal X-ray, or when you're suspecting a perforated viscous. Again, CT is a better modality, but yes, if you want before, because if you think the CT is not available in your center, instead of say sending the patient elsewhere, you can still depend upon X-ray. One is if you to make a diagnosis of intestinal obstruction. Second is to make a diagnosis of perforated viscous. Rarely you can make a diagnosis in rarer entities, but the sensitivity is very low, I'll talk about them. But before that, what are the things you need to see when you're seeing an abdominal X-ray? Anything which is black is air, remember. White is calcified structures or bone. Anything which is gray is soft tissues. Darker gray is fat. You can see I put an R mark. Intense white is metallic objects. So these are the things which you need to, these are basic which you need to know. Most of the time I'll bank upon the upright. How to say with the upright X-ray? You can look for the gastric shadow or any airflow levels or pelvic funneling. Funneling of the pelvis is more seen more in the upright. So one is, but most important is the gastric air shadow. That is very commonly seen. If it is there, means that's upright X-ray or it's a supine. Small and large bowel obstruction. How do you differentiate based on the X-ray? See, as I told you, X-ray I'll make use only when I'm suspecting a small bowel obstruction. If the bowel, see the dilated bowel, if it is more than 5 centimeters, think of it as a large bowel obstruction. If it is a diameter is more than 5 centimeters, think of it as a small bowel loop which is dilated. And if the position of the loops is in the center, think of small bowel obstruction. If it is in the periphery, think of large bowel obstruction. Many number of loops are seen. It's mostly small bowel loops. If only few loops are seen, it's a large bowel. Fluid levels are many and short in small bowel. Long bowel fluid levels are seen in large bowel. Look at the markings across the bowel loop. If they are, it can be valvular conventis or it can be Hostray. How can be seen? I'll show it in X-ray. See, this is a small bowel obstruction because see, bowel loops are in the center. There is no air along the periphery and there is no pelvic air. That means large bowel is non-dilated. So that means obstruction is in the small bowel. And you can see the valvular convent which is going across. You can see across. You can see these lines. I hope you can appreciate these lines going across. So these are the valvular conventis which are seen in jejunum and ileum. Now I'll see the large bowel obstruction. See, you can see the pelvic air. That means there is an air in the rectum. There is an obstruction in the rectum. Distal obstruction somewhere in the rectum. Because sigmoid is also dilated. These are all the peripheral large loops you can see. These are all incomplete marking. These are all the colonic Hostray. See, incomplete. So this is a large bowel obstruction. Whereas the before one is a small bowel obstruction. So we can make use of X-ray to make a diagnosis whether it's a small bowel or large bowel obstruction. So calcification, you can see like renal stones, pancreatic stones, gallstones, uretery calculi, vessel calcification. Calcification, one of the things you can see based on that to make a diagnosis, especially if you want to make a diagnosis of uretery colic, renal colic, calcific pancreatitis, calcific gallstones, something like that. But the sensitivity is very low because this calcification is not very commonly seen. X-ray is not very sensitive to pick up these finer things. Thumb printing, if you see, it's not a very sensitive feature, but if it is there, means you might be dealing with ischemic bowel disease. If you can see an elderly man with a acute onset of severe epigastric pain, see, you can see air below the diaphragm. This means we are dealing with a perforated viscous. This is which can be a duodenal perforation or a small bowel perforation. So again, you can see the air under diaphragm. See, as I told you, memory is very important. Your eyes, if you want to detect this, it has to be a memory in your eye, in your mind. Just make a memory of this picture in your mind. See, this is a thing you're not supposed to miss. This is an air under diaphragm. See, this white is a diaphragm. This white is a diaphragm. And you are seeing an air along, which is a crescentic air shadow, both the side below the diaphragm. So this is 99.99% we are dealing with a perforated viscous. Call surgeon, prepare the OT, call anesthetist. This patient requires an emergency surgery. Plain X-ray, not cost effective, but what are the things you can make a diagnosis? Free air, hollow viscous perforation, cholelithiasis, renal calculi, sometimes intestinal obstruction, calcification, incarcerated hernia can be dealt, fecolids can be dealt, as shown in the previous pictures. gallstone ileus, portal vein air, thumb printing, obliteration of the shadow. Next comes ultrasound. Ultrasound is a very important modality. The reason is cost effective, cheap, widely available. You can get the ultrasound machine straight away into the casualty. You need not send the patient to the radiology department. So when do you use ultrasound? So when you're suspecting liver pathology, when you're suspecting gallbladder pathology, when you're suspecting ectopic pregnancy, tube ovarian abscess, ovarian cyst, you can make a diagnosis with certainty of more than 90% in these situations. So try to use ultrasound when you're dealing with these things. Ultrasound has a special role. It's called FAST. It's any center which deals with a lot of trauma has used this called focused abdominal ultrasound for trauma, because as I told you, hemoperitoneum, you don't waste time sending the patient to a investigation by CT or MRI or X-ray, because those patients will have to go directly from the emergency room to the OTs. How do you diagnose? Because the ultrasound probe, if you put the probe in the epigastric towards the chest, you can make a diagnosis of the pericardial tamponade. Very important. If you put the probe in the behind, you can look for splenic rupture. This can happen post-trauma causing hemoperitoneum because of splenic laceration or splenic rupture. You can put in the probe in the right upper quadrant to evaluate for hemoperitoneum due to liver lacerations. Similarly, you can put a probe in the hypogastrium, you look for any uterine ruptures or urinary bladder ruptures. Mainly look for hemoperitoneum, look for free fluid. When there is a free fluid in a trauma patient, always think of a possible hemoperitoneum. Then look for a solid organ damage, like which can be liver, spleen, bladder, urinary bladder, uterus, or it can be pericardial tamponade. So very important investigation where you can make use of ultrasound in the emergency room. CT, very, 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 very important investigation, especially after you ruled out all those 4 diseases. As I told you, ruptured aortic abdominal aneurysm, ruptured ruptured ectopic pregnancy, or ruptured hollow viscous rupture. If you ruled out these things, and also acute mesenteric ischemia with hemoperitoneum, then if you ruled out these are this entity you ruled out, then you can use CT, because CT is a very important. As I told you, you cannot make a wrong diagnosis. You cannot send a patient to surgery for a non-surgical entity. Similarly, you cannot keep the patient waiting, requiring a surgery. So make use of CT, especially after ruling out a very important entity like wherein you need to send surgery immediately. If those are ruled out, then you can make use of CT. It's a most versatile test in acute abdomens and is most important next to history and physical examination, but to be avoided in patient with already diagnosed with hemoperitoneum, because you made use of fast to make a diagnosis of hemoperitoneum. Those patients will go to the OT immediately. And it more than 90% sensitive for pancreatitis, appendicitis, cholecystitis, diverticulitis, and mesenteric ischemia. Suppose when acute abdomen patient present to you with shock, always suspect organ rupture, which can be spleen, ruptured abdominal aortic aneurysm, ectopic pregnancy, or ruptured ovarian cyst. So finally, key messages. 2/3 of attacks are typical, 1/3 is atypical. Acute cholecystitis and perforated duodenal ulcer are rare, especially less than 20 years. Acute diverticulitis is rare in less than 30 years. And 80% of patients with bowel obstruction have an history of previous surgery. And 70% of patients with cholecystitis will have an previous attacks of biliary colic. And acute abdominal approach should be a thorough history examination, which is the best diagnostic test. Do not rely on the lab or radiology films to exclude pathology. It has only a supportive role. And it is important to identify a need for surgical intervention. CT has an important role after exclusion of an emergency laparotomy. So a small think about any thought about on this case to make you interesting. I put this case towards end. 23-year-old female came with acute abdominal to the emergency. This patient had similar pain in the past, but assumed it to be appendicitis and underwent appendectomy, but found to have a normal appendix, post-op specimen, and after admission this time developed generalized seizures. And next day she developed respiratory arrest because of lack of because we could not make a diagnosis, and the patient was kept on ventilator, finally succumbed after 2 days. Any thoughts? You can put in chat box. Now I'll put reveal it. So, and urinary bag revealed dark colored urine. So if these are the rarely happen, if it is there, think about this is a diagnosis, acute intermittent porphyria. No, don't miss this entity. Normally you get a previous history of similar pains. Most of the time gets aggravated with fasting, and sometimes if you give dextrose, it will get subsided. Even if you give simple analysis and dextrose also, it gets subsided, but sometimes it might not subside. So acute intermittent porphyria, it's normally referred as neurovisceral crisis, present with a recurrent abdominal pain with neuropsychiatric symptoms. Normal precipitating factors that can be drugs, infection, fasting, smoking, or alcohol. Rare diagnosis, metabolic causes, think about lead poisoning, acute intermittent porphyria, DKA, yes, soft abdomen, severe pain, high sugars, urine ketones positive, diabetes dorsal, we are not seeing. Sickle cell crisis can also be a possibility. So thank you for your patient listening. I think I made it a very clear to the how important is acute abdomen, how to make a diagnosis, which investigation to choose, when to send the patient to a surgery, and finally, when to consider this patient as a non-significant abdominal pain. You can ask now, the forum is open for questions. If you have any question, you can put it in the chat box.
Yes, sir. Thank you so much, sir, for this detailed explanation on the topic. Yeah, we have some questions already posted in the chat box. There is this question from Kiranmai Reddy. What's your threshold for surgical referral in borderline cases?
So one thing is make a clinical diagnosis. Are we dealing with acute abdominal pain or chronic abdominal pain? Patient had a similar abdominal pain. Now the pain has subsided. Vitals are stable. Basic investigations are normal. WBC is normal. No tenderness, no guarding. If you're not able to make a diagnosis, you can make help of a CT abdomen. Or if you're not certain with your diagnosis, yes, because this is not an emergency, you can refer to a patient to a specialist.
Thank you, sir. And there is some interesting question from Sai Vinay. What role does point of care ultrasound focus play in the initial evaluation?
So unless you are suspecting a trauma, if it is a trauma, then that is the one thing is a point of care. Rest of the things, I think, make a clinical diagnosis. As I told you, 5 differentials. Are you dealing with the liver, gallbladder, ovarian cyst? So these are the some of the places wherein you can make use of ultrasounds.
Thanks, sir. There is this question from Shivakumar. How do you prioritize imaging in a case where clinical findings are inconclusive?
So it depends on what is the diagnosis you are making. Suppose if you are suspecting a acute abdomen, you're not sure or you're dealing with a pancreatitis or a perforated viscous, then I prefer you do a CT abdomen. Suppose if the pain is confined to right upper quadrant, patient is relatively stable. If you're suspecting it to be a biliary colic or cholecystitis, or it a urinary colic with the pain is right lumbar pain, vitals are stable, no guarding, they can make use of ultrasound. So what investigation you choose depends upon what is your diagnosis. If you lack facilities, for example, for doing a CT scan, you can depend upon ultrasound. Very good ultrasonologist can make a diagnosis. Sometimes you can depend upon X-ray. Go back to my differentials. What differentials dictate what is an appropriate investigation in that particular context? If the CT is not available, yes, you need to make use of ultrasound, some important clinical judgment that you're not dealing with an emergency situations like a perforated viscous, or you're not dealing with the hemoperitoneum, solid organ ruptures. So these are the things wherein you cannot wait.
Okay, sir, that's great. This question from Kalyani Reddy. How would your approach differ in a post-operative patient presenting with acute abdomen symptoms?
So patient has a colic abdominal pain, bilious vomiting with a distension. That's a clear-cut diagnosis of acute intestinal obstruction. So bilious vomiting, vomiting relieving the pain, distension, colic abdominal pain. As I told you, these are the classical symptoms. But if you're dealing with a colonic obstruction due to adhesions, distension is the predominant symptom. Bilious vomiting can be there. Gaseous distension, think of it in the previous. See, first and foremost, with these three classical symptoms, are they think of an intestinal obstruction.
So, this question from Sonu. Could you elaborate on how the approach differs between pediatric and elderly patients with acute abdomen?
So I don't have much experience in the pediatric, but see, pediatric people, what is the most common thing which you don't want to miss is Meckel's diverticulitis, acute appendicitis, or intersusceptions, or when the patient present intestinal obstruction with bilious vomiting, features of interception, think about bands, small rotations. So these are the entities which are more common. Other entities like pancreatitis can happen in anyone. So other entities, I mean, exclude and put all the other things. Gallstones cannot be seen. Ureteric colic cannot be seen. Obviously, any gynecological entities cannot be seen. So whatever I mentioned, consider those as a possibilities of the cause of acute abdomen when you're dealing with maybe a toddler or neonate, or maybe child less than 15 years, any child less than 15 years.
That's all for the Q&A. I appreciate, sir, your patience in answering all the questions very clearly.